Yeah, hello. Um, I'm Janos Tolias. I'm the legal lead on AI in healthcare at the Directorate General for Food and Health Safety in the European Commission. I would like first to thank the organizers for giving us this slot to discuss AI in healthcare. As you know, AI in healthcare is advancing quite rapidly, and at the same time, we have many challenges also advancing with this rapid evolution on AI. So always there is new things to be discussing about AI, especially with these rapid advancements. So today we have we'll structure we have around 1.5 hours, and we'll structure it in the following way. I will start to present to you a study that we have published a few weeks ago dealing with AI deployment in healthcare, what are the challenges and so on, accelerators. Then we'll move to Fulvia Raffaelli, who is the head of unit in digital health in DG, in the Directorate General of Health Safety, Food and Health Safety in the European Commission, and she will talk about the European health data space. As you know, data is a very much importance, of great importance, but also the other side of the coin on AI. Without data, we cannot go anywhere with AI. So she will describe and explain to us the European health data space that I'm sure you may all have heard of. Then we go to Saila Reine, who is the head of unit on AI in healthcare and life sciences in DG Connect in the European Commission, who she will talk about the initiatives of the European Commission in the area of AI, and also refer to the Apply AI strategy of the Commission that was published last week. So very fresh new stuff. Then we go to Regina Bitstan, who is a professor of radiology and the scientific director of the European Institute for Biomedical Research, who she will talk about the so-called Compass AI project, which builds on our study, connects with the Apply AI strategy. So some exciting, which is co-funded by the European Commission too. So quite interesting stuff there. Then we go to Carlo Tacchetti, who is a professor of anatomy, a director of strategic studies program on AI at San Raffaele Scientific Institute in Milan, who he will also tell us about his projects and about AI in clinical practice, deployment challenges, and so forth. And then we'll go to Mark, who is the Sheila Lubensky-Birnbaum Professor of Civil Litigation at NYU Law School, who he will talk to us about liability. As you know, liability is always at the center. Whenever we discuss AI, always liability is in the center. So thanks a lot to Mark. Also special thanks for coming all the way from the US to be with us physically today. And that's how we could proceed. Then we'll go to questions after the 5-minute presentations, and then we can also get questions from you, and we can have it a bit more interactive as to how things are evolving. Okay, so I may now start with my presentation to give you a gist of the study we have, as I said, published a few weeks ago. Just to give you a bit of background very quickly, in advancing AI in healthcare, and I'm sure you'll know, there is 2 critical components there. One of them is health data, unlocking health data. Without data, you cannot develop, you cannot research, you cannot deploy AI. So data, we know that is important. And what did the Commission do with data? And of course, Fulvia will say more about that thing. There was the so-called European Health Data Space regulation adopted in 2025, which is split into 3 pillars: primary, secondary, electronic health records. And all these 3 pillars are quite important and have implications on AI. So without these 3 pillars, maybe AI would have been more challenging to develop, to use, even in clinical practice. Then we need also trust and acceptability to really scale up AI. And what has the Commission done in the last 5 years? First, and I'm sure you all heard of it, the AI Act. The AI Act, of course, it encompasses many different issues there, but one of the important parts of the AI Act is also ensuring the safety of these systems, because if you don't have safety of the systems, then we have been challenges in deploying them and using them, especially in the area of healthcare. So it deals with a lot about regulation on safety. Then last year, we also had the Product Liability Directive adopted in December 2024. And of course, the Product Liability Directive, it makes some changes. It's an amendment of the previous one. And of course, I also put it there because product liability doesn't only occur after something happens, after an accident, but it could be also having an influence as to how you develop the product. So the AI Act and the Product Liability Directive jointly could be having an influence on the developer, how you develop your product. However, less attention has been paid, and of course, justifiably, because this previous work has been very much the foundation to start understanding AI. But less work has been paid on deployment. How do you take AI from the shelf and you integrate it into the clinical workflows, you scale it up, you take it down to the hospital? And this is why we also got curious to see that there is a lot of research development, but kind of slow deployment. What were the reasons for slow deployment? What is the problems there, to try to dive deeper into the clinical practice and make this bridge, maybe this kind of another bridge there from data all the way down to clinical practice. And this is our study that we started around 1.5 years ago. Just to move quickly without getting you to, so we have more time to discuss. First, in this study, we identify the challenges. What were the challenges in healthcare systems and so on? I'm sure you have all heard of many of these: chronic diseases, aging population, shortages of healthcare professionals, a number of challenges there from different sources. World Health Organization also has good work on that one. And this is what we also found. And this is where artificial intelligence could be providing some solutions to these challenges. So that's also the benefit or the idea of using AI. However, despite the, as I said, the advancements in research, advancement in development, also a lot of now products are CE marked, FDA approved. So we have quite a lot of products. Deployment remains slow. So this was also a bit the question for the study. Why there is a slow deployment? What are the challenges? What are the accelerators to also understand this ecosystem of deployment? So the objective of the study was to identify first the current and future needs in clinical practice that AI could address. Then it was to assess the most prominent sector-specific challenges and accelerators. So what are the challenges that we are facing and how could we overcome those challenges, and hence what it could be done at hospital level, at EU level, at different levels. And to understand this, we drew inspiration. Actually, we did deep dive interviews, workshops, surveys, case studies, and we looked beyond the 27 member states of the EU. We also searched the USA, Israel, and Japan, as well as there is some information from the UK and even a couple of cases from South Korea. But so we also went to advanced countries and hospitals around the world to exactly see how they do it and combine practices and so on, to see good common practices, what went good in certain cases, what went bad, and to take some, to draw some common denominators between all those. So this, of course, this is not a Eurostat now survey, a big survey. It's the survey we carried out, what inputs we got, and so on. So it's, as I said, it's not a official big EU survey or world survey, but I think it gives you this graph quite what we would have expected, in the sense that we actually interview here the surveys addressed at healthcare professionals, hospitals, and developers. And they were asked actually there is more details in the study, but I think this gives the punchline of what is happening, what AI could already address. And as you can see, a very high 83%, it goes on organizational workflow efficiencies, so the administration is quite high. So they feel quite comfortable, in other words, with administrative tasks of AI, with organizational stuff, and so on. So they feel quite comfortable with that type of AI use. Interestingly, and again, it's expected, if you go on the other extreme of the graph, you see that the developers are also indicating that it could be giving predictive analytics for patient outcomes. So, and again, you can see there, which again is quite expected, I would say, that the healthcare professionals, the blue line, they're a bit more conservative overall as to how AI could be used. And of course, it could be different reasons. You can see, because in the survey, we ask them, why do you answer this, that? And you will see, of course, it could be liability. It could be that maybe there is no explainability of AI. It could be job displacement. It could be a lot of reasons why, but you can see that the blue line, which is the healthcare professionals, are more conservative overall compared to the developers, which are a bit more on the excited side, and somewhere a bit the hospitals. Now, then we also ask them within the next, if I'm not mistaken, 3 years, how do you see AI developing and so on? So you see the administrative support is boosting up quite a lot. So they feel really confident that within the next 3 years, administrative work would be done by AI. Two things maybe here which are interesting is that when you are, of course, you also see, you see the line, the blue line, increases with assisted diagnostics. So they also feel more confident that within the next 3 years, 3 to 5 years, we'll see also AI moving into this area. However, you can see it's a very low confidence there when it comes to AI in assisted surgery. So autonomous AI performing surgeries and so on, this is quite low in the results, as well as treatment decisions. It also scores quite low, and maybe Carlo could be able to tell us more why there is this, why they feel less confident when it comes to individual treatment decisions, predictions, and so on. It's interestingly that also scores quite low. Now, just to give you a bit of a mapping, the landscape a bit of what was approved in what medical specialties and so on. Of course, here we compare a bit US and EU. In the EU, I have to say, we're still building the database. So of course, they do reflect both sides of the Atlantic. They do reflect a bit the same results, but this kind of reflects a bit more FDA. But as I said, more or less, we have the same results in the EU with CE marking. A big part of it, as you can see, a big part of the pie chart is radiology. A lot of radiology AI-based medical devices which have been approved either by FDA or in the EU. Then it's followed by cardiovascular, then we have neurology, then we have gastroenterology and urology, and then the others. So you can see how a bit the development and the regulation, what has been approved there. Maybe this is one of the most interesting slides of the study. What are the challenges? Why do we have this slow deployment? And there we try, of course, they were different. I have to say, it was kind of challenging. There were different results there, depending on the hospital, depending on the country. If you were in the US, a very big private hospital maybe had different things in mind compared to very small hospital, depending on the system and so on. So it was kind of challenging, but we could see some common denominators there, the common themes that were coming up. And there we split the challenges into 4 groups. The first one, technological and data challenges. And here there are challenges like the infrastructures of hospitals. Can they accommodate the AI? Can they integrating outdated IT infrastructures? So all this data interoperability between their systems, and the medical devices. So a lot of these issues were raised. Secondly, regulatory challenges, and here, of course, liability was also one of the big concerns, but also the complexity of regulation. We're also getting that there is a lot of now regulation on data, AI, liability, and they are a bit in this confusion that sometimes they prefer to not do anything in order to understand the regulation. They don't know how to navigate that bulk of regulation now that exists. Thirdly, organizational business challenges, lack of funding, they couldn't see the added value. If they want to invest on a system, they didn't know which system they should invest first on, if it works well in their environment, why they should choose A or B system, and so on. So a lot of issues also in that one. And then what we call social and cultural challenges, which was concerns of a job displacement, over-reliance, and so on. Then this is an example of how we've seen a good practice of how these challenges were addressed, because we're also looking at how these challenges could be addressed, or they were addressed in certain parts of the world or in certain hospitals, so we can get some good deployment practices. And then there was some future considerations in this study as to what it needs to be done, maybe at different levels, to scale up safely, effectively, efficiently AI in healthcare. And some of these is what now we take to the next level in the Apply AI strategy, in the Compass AI project that it will kick off, as Regina would say, in a couple of weeks, and to now start basically trying to address these issues. Okay, so I stop here. Thank you. And then now we have Fulvia to continue with the data part.
So good morning, everybody, and thank you, Janos, and the organizers for giving us this opportunity to really dive into the fascinating world of the use of AI in the healthcare sector. So the one that you may know me, they may know that I have 3 boys: Samuel, Nicola, Daniel, and since a couple of months I have also a newborn, which is the European Health Data Space. It took us, let's say the pregnancy was a bit longer than expected, a couple of years, but at the end we have it. And that's the fascinating project we are at the moment working on, and where this really project is so important that we see it as a catalyzer for the transformation of the healthcare sectors altogether, and as a foundation for the safe deployment of AI in that sector. As Janos said, indeed, the European Health Data Space is a very ambitious project because it is population-wise. We have 3 main objectives. This is the primary use, of course, of data, which is about personal data from the patient and from the people to be able to access their own data immediately, free of charge, wherever they are in the EU. This is really also creating the infrastructures to make this exchange, this access, cross-border access possible across member states. And at the moment, we are working very closely with the member states to actually make it happen by 2029. We have a voluntary system that is already up and running in many areas, but this will be fully available from 29 on. We have also the secondary use, and the secondary use is making all this data, so again, population-wise data, available for research of innovation under very, very strict conditions and respect of privacy and purposes. Those data, this is where the HDS is creating a sort of Copernican revolution. So not only data which are today collected for research of innovation would become available, but also data which are today collected for primary care and for continuity of care will also be part of that, that are in the scope of the European Health Data Space and will become available for this. We also harmonizing the health record systems. This is the tool, is the means that would actually make this interoperability of data possible at the EU scale. And why this is so important, I mean, I don't need to tell you why this is so crucial for the future of the use of AI in healthcare. Because of the challenges that János explained to us, one of the main challenges is indeed the availability of data and the today still difficult access to those data. They are stored in different areas, of course, different hospitals, different medical centers, many research centers. They are today accessible via specific digital infrastructures, which are amongst members of those, let's say, clubs, but they're not yet, or they're very difficult to access and to pull together in an integrated and reliable format. That's the challenge we have in front of us, where the European Health Data Space can really bring and make the difference at the moment when we're there. Here you see a quick timeline. So we have now 2 years to set up all the technical specifications to make those data interoperable and accessible from in cross-border situations, and we'll then have 2 years for the member states and for the different stakeholders to be able to comply with the obligation. Because here we're speaking about obligation, so not a voluntary system anymore, but really a mandatory system that would actually make this change a continental level. So. This is really crucial, because the Commission, we are laying down the legal foundation for a trustworthy AI in healthcare. European Health Data Space is about data, but of course we do have also the AI Act, and János mentioned that before, and also other legislations such as the GDPR. And all together, those legislation actually make the EU regulatory framework safe and really trustworthy for the different stakeholders. So this is all not only about creating a technically interoperable environment, but also a very in-depth transfer system, so that this can reassure actually from, first of all, the patients that their data would be used only in a secure transfer way under very strict conditions of governance and with privacy by design, will reassure the researchers that they can really have access more easily than today to those data, and that they can also rely on more fair and less biased data for the future of their validation systems, and they will also reassure the policymakers and of the future that those data would really be available for them to support in the decision-making process. We are together today trying to support that. As I said, we have a bit of time still in front of us, and we need the support for the different stakeholders. We have launched in 2025 two very important projects, which are at the moment open for your applications as well. One is the SHAPED project, which is about supporting the health data access body, which are the national authorities responsible for granting authorization for the access to secondary data use, in building pathways for AI deployment, in using the health data TU infrastructures, which is the one for the secondary use in the European Health Data Space. And we have another very important project, which is about advancing AI in healthcare, to be launched now. Actually, is open the call, and this is about setting up a European AI expert community to develop good deployment practices and to pilot projects, so that we can scale up what already exists today and what is still to be, let's say, tested and deployed at scale. So with that, we hope really to support the further deployment and to move to be able to support the change from the research stage, where many of those projects that are based on AI solutions are still, let's say, today not stopped but limited, and then to move on a deployment scale so that they can be integrated in real life, in the clinical workshops, in the clinical workflows, in the hospitals and in the medical center. And for that, we need also the support, horizontal support of the Apply AI strategy. And with that, I'll give the floor to my colleagues. Saila, thank you very much.
Thank you very much. So my name is Saila Rinne. I come from another part of the European Commission. I am from the Directorate General of DG Connect, which is the technology department of the European Commission. My unit is called AI in Health and Life Sciences, and we recently joined the European AI Office. The AI Office has more than 100 colleagues working on various aspects of AI, AI Act, safety of AI, innovation hubs, AI for public good, and also excellence in AI and robotics. And of course, we are very happy that we have a dedicated team in the AI Office working on health and life sciences in particular. And that is also a sign that health and life sciences are really at the forefront of as an application area for AI that the Europe wants to support. I would like to first start with the big picture. So one of the top priorities of the current mandate of the European Commission is to make Europe an AI continent. And earlier this year, the Commission presented the so-called AI Continent Action Plan with the 5 main pillars that were on computing capacities, data, skills, regulatory simplification, and boosting uptake of AI, which is the Apply AI strategy that was published last week. When it comes to the computing capacities, the Commission has selected, together with the Euro HPC joint undertaking, so this is the high performance computing network of HPC centers, 19 so-called AI factories have been selected across Europe. And these AI factories are supercomputing centers with specific capabilities to accommodate the use of AI together with large amounts of data in different sectors. And these data pools are called data labs. And 16 out of the 19 AI factories will be specialized in health and life sciences, which is great news, of course, for us. There are also other sectors, of course, that are going to be covered for these AI factories. But this means that there's going to be a lot of investment and effort in building data labs and dedicated computing capacities for health and life sciences. The next step in these AI factories will be to fund also a few so-called gigafactories. And for that, we are foreseeing 20 billion euro investments from public and private sources. And there was a call for expression of interest for the gigafactories. The Commission received over 70 proposals for such gigafactories. Of course, we cannot fund more than maybe 4 or 5. So now the Commission is assessing these proposals and also thinking of combining some of them in order to have like solid gigafactories in place in the near future. Then when it comes to the data, Fulvia very well presented the state of play with the European health data space. The Commission has been also supporting health data infrastructures on imaging and genomics, for example, and all these regulatory efforts and infrastructure efforts will be instrumental in creating specialized data labs around the AI factories and in establishing connected, secure and interoperable European ecosystem for AI in health. Then for the regulatory part, the AI Act will of course bring the legal certainty around market uptake of AI in health. And when it comes to health applications, it also the medical device regulation is very relevant here, and the interplay between the AI Act and medical device regulation will be ensured, and there is already a first set of guidelines in place and published. The AI Office also launched last week the so-called AI Act Service Desk, which is now up and running. The purpose is to provide answers to questions from stakeholders on specific questions on application of AI Act. And there is also a so-called compliance checker that the stakeholders can use for this purpose. The Apply AI strategy was published last week, as I said, together with a strategy on AI in science. So these two go hand in hand. There are also dedicated actions that the Commission is supported on advancing the state of the art of the AI and also on advancing the AI and advancing use of AI for science. So it's like AI for science and science for AI. And so that is a separate strategy, but it is interlinked with the Apply AI strategy, which establishes sectoral flagships to harness AI's transformative potential, driving adoption across 11 strategic sectors, one of them being healthcare and pharmaceuticals. It also addresses cross-cutting challenges like supporting SMEs, enabling an AI-ready workforce, so workforce and skills, very important, and leveraging advanced AI capabilities, so AI factories, the gigafactories, and ensuring trust in the market. So these are the cross-cutting topics in the Apply AI strategy. The strategy also fosters collaboration through the Apply AI Alliance, which is a forum bringing together policymakers, industry, academia, and civil society. And there will also be a so-called AI Observatory, which will track, process, and monitor progress with specific indicators, progress of adoption of AI, and also provide insights into the AI developments. In healthcare, the strategy proposes establishment of a European network of AI-powered advanced screening centers, and also a European network of expertise on AI deployment in healthcare to consolidate guidelines and best practices. And it also announces an AI drug discovery challenge for potential new therapies and to address unmet clinical needs in order to streamline and enable quicker market entry, also to enable quicker market entry of medical devices without compromising safety. So here we already have some actions that are actually answering to the issues that Janos was presented in the first presentation on the challenges and obstacles. And the idea is also that the Apply AI Alliance will be also a feedback mechanism to the European Commission, and that there would be a dialogue, and that feedback would also lead to further actions and initiatives based on stakeholders' needs. Thank you very much, and looking forward to the panel discussion. Thank you.
So good morning, ladies and gentlemen. I am here to represent the medical professionals. I'm the radiologist. In our field, we have been working with digitalization already since decades, 2.5 decades. So that's why we're sort of ahead in AI, and that's where we also have all these educational activities already since like 5 years. Now, why is this deployment an issue at the moment? First of all, the helicopter view. We know that rising healthcare cost is there because of the aging population. There is a rapid advancement in medical technologies that's always implemented, but not always scaled back when ineffective. There's an increasing administrative burden, workload for medical professionals, while we have persistent workforce shortages. So we need a more effective and preventive and patient-centered care. That is what I believe. And that will happen with digital transformation of healthcare, because there are already proofs that AI can improve more personalized treatment, enhance the equity in care, because AI really benefit those regions that have not the subspecialized expertise, improve access to screening. In the radiology world is breast cancer screening powered by AI, detects more breast cancer, improve workflows and reduce workload. So the AI deployment in healthcare is a present demand. But what is the problem? The problem is, as Janos has already explained from his study, the gap is the deployment at scale. So that's why I'm very pleased that from the EU for Health funding project, we could start, the kickoff is in fact next week, this Compass AI project. And the main objective is to accelerate a safe and effective AI deployment in healthcare, with special attention to cancer care and healthcare delivery in the remote centers. The Compass AI will build on six main pillars. First of all, and I think that's the most important, is to get all stakeholders together. So we will establish a multidisciplinary community of experts, including medical professionals, IT specialists, hospital administrators, patient representatives, policymakers, etc., etc. And we will identify together the challenges and success factors for safe and effective AI deployment. We will then develop best deployment practice guidelines, and we will not start from scratch, but base it on an existing framework was also funded and developed by EU for trustworthy AI. Now, these best practice guidelines we will validate in real-world pilots in diverse clinical settings, as you can see, in radiology, pathology, so diagnostics, towards surgery, treatment, and even primary care. We will try to do this pilot both in the advanced and in the remote center context, because then we can really grab the differences in weaknesses and strengths of deployment of AI and see that difference and learn from the experience. We will do local performance testing. What does it mean? AI can work well, but does it also work in our own patient population or with our own imaging machines? So that's very important to know. We will do local validation. Is deployment of AI feasible? Does it integrate seamlessly into the clinical systems? Do the professionals really get better treatment decision-making? And does it impact outcome? Does it impact the workflow? Those are very important questions. And of course, we need to be able to maintain the safety of the performance of AI, because AI is a living, continuous learning process. So the context changes, population case mix changes. machines changes, and we need to be able to monitor those changes and flag it, and again test it when we need to adapt it. We will also create an interactive dashboard. What it is a map where you see all the centers who have deployed AI and see where it works and where it not works. And if it doesn't work well, that we can immediately act and explore and investigate what's happening there, how can we improve, and how can we learn from that experience. Set up an educational program, of course, to educate the end users, the actors, including patients and public, on the best deployment practice and AI literacy. And in the end, we hope to deliver a practical, evidence-based, step-by-step operational guidelines for trustworthy AI deployment in healthcare, tailored to the individual clinical settings, because there's not one size fits all center. We will deliver policy recommendations, inform the policymakers how to safely deploy and accelerate AI in healthcare, and that will be aligned with all these EU initiatives. So that's why I think this is the moment now, aligned with EHDS, AI Act, and the Apply AI strategy. Of course, we will continue collecting the evidence and learn from it and share these best practices by having this EU-wide interactive dashboard. And in the end, we hope to have EU reference sites that can help all the providers who would like to start deploying AI, maybe do the local performance testing, in the end, ultimately to generate robust evidence for a safe, scalable, and equitable adoption of AI across Europe. Thank you very much.
Okay. Good morning, everyone. Thank you for the invitation, Janos. So I'm Carlo Tacchetti. I'm an MD and oncologist by training. I'm professor of anatomy, and I've here because I have few questions I would like to be answered, and I have been trying to find the answer with no success so far. So let me state a few things before starting. First of all, medicine is not an exact science. In medicine, 2 plus 2 does never equals 4. It's 4 plus or minus a certain amount of error. This error depends mostly on our ability to stratify patients based on data. Now, we have a lot of data now that we have to analyze, and this data can only be analyzed through AI. As we have seen, there are many solutions already deployed, which are in the diagnostic field. However, diagnosis mostly focus on the lesion of the paper. If we talk about cancer, we'll only focus on the specific cancer lesion. But patients are not do not equal the disease. A patient is a more complex system. A patient is the disease itself, but also comorbidities, the therapy that is provided for the comorbidities, the side effects of those therapies, lifestyles. Not everyone knows that if a patient with cancer lives 50 kilometers from a reference cancer center, has a low survival expectancy than a patient living next to a cancer center. So we cannot focus only on diagnosis. And we should extend our wishful thinking to what is prognosis and therapy response prediction. Just to make you an example, if we take a lung cancer patient with non-small cell lung cancer, is subtype of cancer, PD-L1 expressing. PD-L1 is a protein that says to the immune system, do not attack the cancer, leave it grow, okay? We have a specific therapy to that protein. So we have patient with the same type of cancer, same type of target therapy, same type of therapy. You would expect 100% of the patient responding. Instead, only less than 45% of the patient to respond, meaning that we are providing a non-effective therapy, and then that means side effects to 55% of the patient. Each of that patient costs to the health system 100,000 euros. So basically, we are also missing the point of stratifying those patients, so to identify the cohort of patients to whom we could provide an alternative therapy, because when we understand that that therapy is not working, it's too late. So what is my wishful thinking is we should look forward from diagnosis. Diagnosis is very important, focuses on the lesion. I would like to have predictive models in prognosis and therapy. Now, where do we stand? We made an analysis on PubMed and also analyzing work done by others. And out of 230,000 publications stating AI and artificial intelligence in medicine, less than 13% had a quality standard which reached the level of acceptable. Less than 10% reported trustworthy explainability, security, and explainability solutions, meaning most of those papers are not useful. If you go to FDA and you see from 95 to 25 how many devices have been approved based on machine learning AI, there are 950, 230,000 publications, 950 devices. Less than 2% of those devices report a clinical study supporting the solution, and less than 3% of them have planned post-market surveillance studies for security reasons. Goes by itself that 97% of those were approved through the 500K process, which is basically a substantial equivalence to some devices that was already approved before. So we have a problem here, and the problem is, do we need predictive models, and what we can do to get predictive models? What we have done at San Raffaele is start from scratch. We started defining all the problems related to AI Act, risk management framework, GDPR. We studied all the regulation. We defined a pipeline, a workflow of processes, standardized processes and protocols to develop predictive models. And then we developed, based on these standardized processes, a unique platform that is now deployed since last year in our hospital. And we then, together with other colleagues, gathered together to create a European network, which is called EU TRAIN. TRAIN stands for Trustworthy, Responsible AI Network. Within this network, we are sharing our experiences, our standardized protocols, and we also share somehow technology. We published in February this year a paper on JAMA reporting which are, to our knowledge, the possible standardized processes and protocols we should apply. If we apply these protocols, we will have certified models from the beginning to the end. Each step will be certified. Now we have a third problem then, and then I'm finished. While we have regulation to approve new drugs, we have regulation to approve new devices. We do not have the regulation to approve new algorithms. And an algorithm is not a device. An algorithm is not a drug. It's something different. So we need regulation on how to approve modeling in prognostic and therapy response. And I finish to say that we also need the EU Commission to be proactive in identify infrastructures already set up in Europe that can create a network of infrastructures. It's important to, the health data space has been a great, and it is a great experience. We now have to go to analysis. We need infrastructure that are certified in order to release predictive models. And that's something that also EU TRAIN network is trying to do. And I thank you for the attention.
Hi, I'm Mark Eisfeld. I have a low-tech presentation, so I'll just sit here instead of going up to the lectern. I'm a lawyer. I'm not a computer scientist nor a doctor. I'm here primarily because I'm running a large project by the American Law Institute called Civil Liability for Artificial Intelligence. The idea here is, as one hears frequently, one of the primary reasons, if not the primary reason, for the slow deployment of AI systems involves liability concerns. If you do it, will you get sued? And if you get sued, for how much? Is it worth it in light of all of that to go in this direction? And so there's already laws applicable to AI. You don't require an EU AI Liability Act that was shelved. In fact, liability already exists under the recently revised Product Liability Directive. In the US, you don't need federal legislation creating liability for AI. It's already done at the state level by way of tort actions for medical malpractice, products liability, and so on. Now, the difficulty in both the EU and the US is that the liability issues involving algorithms are extremely complex. They're just very different from tangible products and human-provided services. And working through how those differences affect the liability rules turns out to be quite hard. Now, traditionally, you do that through the court system. We have case-by-case adjudication. Somebody's injured. You argue about what is required for safe practices and so on. That is not a very good model for a fast-moving environment that we're now facing. And so the project that I'm in charge of, the organization has always played a prominent role in specifying the legal framework of liability rules in the US. And for example, the rule of products liability in Europe and around the world is modeled on a rule that came out of the American Law Institute in 1965. And that process effectively involves meetings about the size of this one, in which me and my co-drafter will present material on what we think is the state of law with respect to a certain issue and how we think it works out in the context of algorithms. And then the room, which is full of judges and other law professors, lawyers representing the labs like Google DeepMind and OpenAI, attorneys who are litigating these cases. We just all have a big conversation and we try to figure out what's the clearest specification of the liability rules in the hope that we can clarify matters. So not only will courts and litigants be able to understand how to proceed, but more importantly, organizations like hospitals and so on will be able to understand how they could responsibly use AI in a manner that doesn't necessarily lead to uncertain or worrisome levels of liability. Now, as a general proposition, it's always been true that concerns for medical malpractice liability creates incentives to not adopt new innovations. You're always safest doing what the herd does, because if things are mistaken, your defense is always that, well, that's the norm in the profession. That's how most people do it, and I'm just following the professionally competent norm in this respect. Of course, medical innovation has always been quite impressive, and there's a couple of reasons for that, despite liability. Obviously there's a lot of money involved in innovation, but there's also a lot of professional status involved, and so there's always going to be both personal reasons and commercial reasons for pushing the envelope. And so medical innovation has gone apace for quite a long time, despite this incentive that I'm talking about. I think medical AI, is going to change things dramatically, in that the landscape is changing so rapidly right now, that the idea that there's going to be a status quo that you can rely on 2 years from now, 5 years from now, or whatever is highly unlikely. You have to just understand it's a dynamic, fluid environment, and you have to hop on for the ride and do the best that you can. Now, I think in that context, it's much easier to navigate this than what it might otherwise appear to be by just thinking about the problem abstractly. Because what's happened with AI in general, and not just medical AI, the data matters massively. And so all of these projects that you're undertaking are going to have a huge payoff for the capabilities of these AI models without question. But the Carlo question of, what about the predictive AI, the ability to treat patients and things moving forward. Now, if you think about, your own use of AI right now, the models have changed in a way recently so that it's no longer simply a black box. Tells you yes or no, and you don't know how it got to that answer. Chain of thought reasoning is now standard within the leading models. And so, as a lawyer, I can, work with AI assistance on a legal research question, and I can have a back and forth with it. And I can understand the reasoning behind the conclusions, the support that it gives, and I can interrogate it just like I would interrogate an associate or a young lawyer who'd I'd task that particular research question with. And so, too, I expect that what will happen with medical AI is exactly the same thing. It's not going to be do treatment X, yes or no, no reasons behind that. You can then, as the physician, say, why X? I think Y. And you can then have a back and forth as to the reasons that the AI model relied on to get to its final recommendation. And you, the physician, you, the professional, can independently assess whether or not the AI's recommendation makes sense. And so the models have evolved in this way so that they're much more collaborative rather than a simple thing where you have to decide whether to trust it or not without understanding how it works. And so it's those kind of developments with the tech itself, coupled with the developments in the data itself, that I think holds tremendous promise in this area. Liability certainly matters, but at the end of the day, it's not going to prevent this enormously valuable technology from developing further and really transforming healthcare, I think. Thank you.
Thanks a lot. I hope we gave you at least some food for thought, to provide some foundations. Maybe you already have some questions. I suggest that we go one round of questions and then we can start being more interactive. And this time, if I may start with the other way around with Mark. And on what you, Mark, said that AI, which is indeed true now, even compared to 2-3 years ago, is becoming a bit more interactive, and we see it. You can start now even interrogating it, Y, X, Y, Z, and you just start talking with it and moving. And two people might be even, I would say, moving to two different directions despite your interaction with it. And of course, in the medical field, it could mean different stuff, the way you interact. So do you think the traditional principles of product liability and service negligence dealing with this classic group of liabilities, it would be fit? How do you think we will be moving into this more anthropomorphic interactive AI, and what type of machine-human interaction type of liability do you see there? How would it be evolving?
Yeah, that's a hard question and a good one. It is going to be the case that the principles themselves don't change, but essentially the principles behind U.S. tort law came from medieval England and went through the Industrial Revolution, and it's going to get through this revolution as well, because essentially they're basically general principles, and you just have to figure out how they apply to the particular technology in question. And so here it really, in the healthcare context, it reduces to the basic idea of how would a responsible physician use a tool, and it's a tool. How would a responsible physician use a tool like this in order to provide the healthcare in question? Now the robotics of all of this are far behind the large language models and so on, because it requires a world model within the robot in order to act in the world. That will happen at some point, but right now, just on the diagnostic side, I think the question to ask yourself is, as is true of any other tool that could help me succeed as a professional, what are my obligations to use this tool in a responsible way? Now, it had been the case, as I was saying, that we didn't actually know how to use it responsibly because it just gave us information, but we couldn't evaluate the quality of that information. But now we're dealing with technology. You really can interact with it. You can evaluate whether or not you agree with it in the same way that you'd have a conversation with a colleague. And so I don't think there's anything fundamentally different about, rejecting a second opinion from another physician on a proposed cancer treatment, how that's going to be different if instead I'm rejecting the proposed treatment from an AI model. You're going to have reasons for following that other recommendation or for rejecting it. And I think that conversation and the quality of it isn't going to change. It's just that you have a different entity you're now interacting with rather than another human colleague.
Great, thanks a lot. And maybe if I go to Carlo. Carlo, indeed, as you said, your work also, and you're focusing in the area of prognostics, therapeutics, individual treatments. And as we have seen also in our study on the graph, it seems that healthcare professionals are a bit less or more concerned with that type of AI. And as you also said, there is less deployment of that one in contrast to diagnostic AI. Why do you think there is that change there or that discrepancy there?
Yeah, first of all, I think your study states what is at present, not what I hope it will be in the future. But what Mark said, it's correct. Now, when you go to imaging, which is the big boom in AI so far, well, imaging has leverage on deep learning approaches in computer vision studies that stand from 20 years from now. In predictive modeling, you cannot use deep learning and not even generative AI at present. You have to rely on machine learning. So it's a different technical approach. While in imaging, basically you have numbers because each pixel is a number or cluster of pixels make numbers. In the predictive modeling, you have a different type of data that can be either categorical or not categorical. I mean, you have not necessarily numbers, so it's more complex. But what Mark said is it's absolutely correct. If we rely on black box models, we fail. It's no reason. As a clinician, I will never accept to use something that I do not know how to explain. But if we combine black box models to identify key features, and then we cluster these features and we develop white box models, as we do, then these are fully explainable. Now, why do I need an explainable model? First of all, I have a problem of paying lawyers, and I would like to avoid that. And so there is a problem of liability and accountability. But secondly, again, as a doctor, when I provide a therapy to a cancer patient, it's not me that makes a decision. I can suggest. It's the patient that decides whether that therapy it's okay or not. I have to fully explain the patient the pros and the cons of that therapy. Now, how can I do that if my model is not fully explainable? That's why I think if we move to standardized processes and protocols that state the rules on which are the characteristics of a model in order to be deployed, then we can move forward in predictive medicine. Thirdly, I would like to say that we are not trying, and I don't want to lose my job, so I don't want to substitute doctors in any way. You know, I still have a family to support. But the point is, all these models add on the knowledge of the doctor. They are not making the decision. They're simply providing extra data. If those data are explainable, then the physician will decide whether to use that or not. The same comes from when I get the data from the diagnostic, from the imaging colleagues, I mean the radiologists, I do accept or not accept that diagnosis depending on my experience. The same I can do with my predictive models. So I would say that I still convinced that we do need predictive models. We have to find a way of doing them in like as it has been for imaging, in a more standardized and approved way.
Thanks a lot. Yeah, very interesting. And I think this idea of protocols, I think that's an interesting suggestion there. If I go to Regina now, Regina, we have seen also in the study, but also in general, that sometimes hospitals are a bit skeptical in adopting AI because you don't see the added value. And of course, the added value is not just saying it's accurate, but they don't see how it will give them added value to their patients, to their workflows, to their healthcare professionals, to the healthcare system. What do you think is a golden standard there to identify how do you provide added value, also financial maybe? I don't know, maybe there is different parameters there. So how do you see, how do we measure the added value of deploying AI in clinical practice?
Yeah, thank you very much for this very important question. And I can also talk from my own experience as chair of the department, what exactly leads to added value. Definitely not the main area under the ROC curve, so the performance of a tool, because that we read as scientists, as medical professionals, and we believe that it's working. But what we do not know is whether it's also beneficial for the workflow. Does it improve our workflow, which is awful at the moment, fragmented, etc., for every patient? But also, does it improve the outcome? If it gives us more confidence to make the diagnosis or to choose the treatment, does it really benefit the patient more than without the AI? Now, and that's why I think that the added value, the best measure is to link that to what is the impact on the organization, on the workflow, what is the impact on the patient. What is very important in that, if I may elaborate, is to understand how it works in your own practice. And a couple of years ago, I think I started with 2 algorithms on the Department of Radiology. And the one was detecting little nodules in the lung, and the other one was detecting pulmonary emboli, so clots in the lung. The first model was not so well accepted by the radiologists because it led to more work. They saw all little things flagging up, and those were not nodules, so they had to look even longer. But the other one, with the lung clot, it was well accepted. Why? Because we did a retrospective study on our own data set on how they performed, the radiologists without the model, and how the model performed. And all of a sudden, they saw that the model was helping them much better. So when I wanted to ask them, okay, shall we buy this model or that model? Then they said, do not throw that away because it really helped us. So I think those are, like outcome workflow, but also for the patient.
Thanks a lot. That's great, actually, to also get this personal experience. Saila, you showed us indeed a lot of work by the Commission, different initiatives, strategies, work, and so on. What is the ambition behind the Commission's approach to AI? So what is hidden behind all this work? What is the big ambition there?
Yes, so as I explained in my presentation, now the Apply AI strategy is one of the 5 pillars of the AI Continent Action Plan. And now really we already have done quite a lot of stakeholder consultations, and we came up with the 4 flagships for the health sector. But this is just the beginning in a way. Also to keep in mind that there were 11 strategic sectors that were covered in this Apply AI strategy, ranging from energy, robotics, defense, agriculture, and so on. So it's a very wide-ranging strategy. Of course, the health sector is a bit different from many of the other sectors, but it's also, I would say, the most ambitious sector in the strategy. And we really aim at having scalable cross-border solutions that can really deliver tangible benefits for patients, healthcare systems, and society. Also fostering collaboration through the Apply AI Alliance and projects like Regina's project, and we really want to consolidate all this work on the stakeholder outreach and to benefit from all the results coming from them, also from studies like the ones that you did in DG Sante. There's one coming up from our side as well. And then we have the AI Observatory for really monitoring the progress, which is also very important, that we show how we are progressing with specific indicators. And this is with like the combination of also the computational capacities and the regulatory frameworks. And this really aims at moving forward in Europe with AI.
Thanks a lot, Saila. Now to Fulvia. Fulvia is, I think everyone accepts, data is really at the heart of AI. And you explained the European health data space, the next steps. How is the Commission ensuring that the health data would be ready for AI? Because sometimes we also get these questions, will the data be really ready for AI as of structured interoperability, representativeness? So what is the impact of the European health data space to make them ready for AI?
Well, thank you, Janusz, for that, which adds pressure on me. I always say no pressure to my stakeholders, but indeed, I mean, we do in the European health data space have that responsibility. This is what we have heard from all of you. It actually relies on getting those AI solution-based, be able to train, but also then afterwards to validate and to monitoring post-market afterwards on data which are reliable. And those and the work we're doing on the European health data space is start with the collection of data at source, because we are via the primary care starting already to identify some element of standardization for the what we call it the priority categories, which are basic one, but includes the electronic health records, which is actually today the wider deposit of basic information about the patient. So with standardizing that format, that first for primary use, we also in the medium long term supporting standardization for all data later on. But it also, of course, relying very much on the work of the ones which are been working in specific areas as the digital infrastructure that Saila mentioned before, in cancer, in images, in genomics, and also in interesting research structures as the one mentioned by Professor Tacchinetti before. So that's it's ongoing, and within the next 2 years, we will work very closely with the member states actually to define those standards and to make those data as interoperable as possible with the work we're doing in the current ongoing Compass AI, but also Shape. We are really making that. So we have the AI in mind. This is not the only use, of course, the only tools that we are preparing for, but this is very, very clear. One of our ambition is that those data that we are collecting for the second that will become available via the European health data space for secondary use are interoperable, are reliable, and they can integrate it also from different sources, because today fragmentation is one of the obstacles with the legal framework that the European health data space, with the digital infrastructure, with the standardizations that we are pushing forward. We hope to be able to actually really improve the situation on the ground.
Thanks a lot, Fulvia. And now maybe we can get some questions from the audience. Oh, actually, I didn't expect this. So maybe we can start from there. Yeah, there. Yes, I think the mic is coming.
Right. Hi, panelists. It was really a very engaging discussion. So my name is Rustam. I actually represent like a digital health startup. And my question is actually more related, more downstream. So we cover like the whole pipeline, good data, after that, good models, after that, and good medical devices after that, good software. So my question is about the step after, which is more downstream. How do we ensure that these regulations and like these steps to work towards deployment becomes encapsulated within the regulation for distribution. So let's say like a software medical device, which is essentially like a slew of AI models that we put together for service delivery. How do we then move it from, let's say, EU, which it has been tested and developed and deployed, to other regions like Southeast Asia, to South Asia? That'll be my question.
Okay, maybe can we get, because I see a lot of questions, we'll try to push, shall we get, let's say, 3 questions and then we distribute? Yes, there.
Thank you. Stefano Wiesbauer, Lectorius. My question is on the legal side. I recently looked at MedGemma by Google and read all the disclaimers, which was interesting. It was like, okay, this is only for teaching and only like, we take no responsibility whatsoever, even though it is kind of a med-specific thing. And I'm curious to hear any reflection of you from the legal side, because, kind of we're looking at building those kinds of functionalities ourselves. So I'm wondering, like, what's your reflection on that? Is that an effective protection for them? And for the practitioner, if he's used it in the process, is there risk for the practitioner? Was it fairly protected because you say like it was just an opinion, so to say? Thank you.
Okay, thanks. So this is clearly for Mark. Yeah, yes, there. Yeah, yes.
Hi, I'm Sofia from PredictMe, a university spin-off in Sweden, and we have an AI model trained on over 150,000 data sets. So obviously, this is incredibly interesting. But my question is, essentially, AI is incredibly broad. It's anything from a physician consulting ChatGPT to, journal systems and AI that are helping with that part, and to more what we're doing, essentially looking at epigenetic data or any bioinformatic data, and then making conclusions and comparing it to other data. So my question is, how can we make regulations and policies that cover it all? Because it's so incredibly broad.
Okay, thank you. Maybe we can pick another one. Yes, there.
Hi, my name is Miriam Montero. I'm a medical student in the Universidade de Cabo Verde, west coast of Africa. And my question is kind of long, so I had to write it down. If data bias is a problem, and I see my professors often complaining about funding through European Union, how difficult it is when European countries are involved in innovations, in the same innovations they are partaking. Is part of European Union's plan to maybe do a synthetic but realistic resampling of the underrepresented group that I believe would kind of help with removing or reducing some of those biases, or do basically resampling peripheral areas where the projects are being implemented, or do some more pilot testings in those regions to fill those gaps that are often seen as bias. Is in the plans of European Union or European Commission to do some sort of a project in that way, in that level, in those underrepresented countries or groups such as Cabo Verde, to help with that bias and give us a more specific data, a more trained data to work with.
Okay, thank you. Shall we go on this round and then we can get even a bigger round? Let's start with the legal question, which is clearly for you.
Okay. So, excuse me. So the question, the one about the general purpose nature of AI, it's without question, I've lost my voice since I last spoke. That's the approach of the EU AI Act, is to horizontally treat the technology. In the US, we're not going to take that approach, I don't think, due to the difficulty of the general purpose technology working out its legal implications across the varied uses. So you have to solve the legal question, in my view, and a lot of others, on a case-by-case basis. Now, in solving the legal question, does it matter whether or not there's a disclaimer on it? Now, this is not anything new. One thing that I always tell my law students is that one thing you get from a legal education is that whatever you read on the ticket or the product or the disclaimer may not be be enforceable. Because of course the seller, the manufacturer, is always trying to protect itself from liability. So to use a tragic example, the instances in which teenagers have committed suicide after emotionally bonding with their chatbots, those apps come along with disclaimers saying, hey, use this responsibly or something like that. The legal question is it designed in a way, is the information communicated in a way that results in the kind of harms in question? And the disclaimer is only a part of that analysis. It's not the end of the analysis. And so, but they're all complicated issues, but they really do require case-by-case determination. You can't just kind of do one fell swoop AI solution that's going to be a one-size-fits-all.
Thank you, Mark. And maybe let's jump to the data question. The synthetic data representative of group, how do we sort biases? Maybe we can start with you, Fulvia, and anyone else.
Yes, so indeed, I mean, we are very well aware of that risk, and with the European health data space, we have the idea of correcting, or at least in the medium long term, by moving from the current approach, which is based on cohort and very not very, but limited, let's say, sample of data to the population-wise. That's where we believe that the change of scope in the accessibility of data can be useful to protect, to correct some of these bias. Because indeed, via the European health data space, will not correct only, we will not make available only data from patients, so for people which is in the hospitals already, but also for people which is not in the hospital yet. So, for instance, people that is undergoing, annual medical check on, and it is fully, or even collecting its own data for its own improving its own quality of life. So that would, in the medium long term, of course, create giving the possibility to correct those bias and to confront, to make correlations between populations across member states and regions. What I would like to say is that to get there, there's still, of course, a way to go, but the many data holders are already starting to do the job of monitoring, mapping the data they have, preparing for the metadata catalogs that will come available at the European level. So creating national metadata and curing more and more and being responsible for the data they own. So this is of course fully fledged. The operationalizing of the European health data space will come in a few years, but already today we see the process of improving and making more aware also of the value that those data have for the research for innovation, but also for the actual use in clinical processes. And this is a process that's been ongoing already for many years in research. It is now sort of getting out from the research centers and really taking up in the hospital and in the clinical settings. That's where we believe that the European health data space can indeed provide our replies to your shortages of biased approach in data.
Yes.
Perhaps I can add that there has been also quite a lot of research done and going on synthetic data in Europe, also under the Innovative Health Initiative joint undertaking, which is a public-private partnership. Just to mention that the genomic data infrastructure that we are supporting to have cross-border access to genomic data, the first demonstrator of the infrastructure is built on synthetic data because it's the most sensitive type of health data. So there is quite a lot going on also in advancing the state of the art of synthetic data in healthcare in general.
Thanks a lot. The other question, I think it has to do with generalization, how basically an AI system, could be generalizing well also in other parts of the world. Maybe Carlo, Regina, how do we ensure an AI system which is developed in Europe, but also a system which is developed somewhere else in the world, it will be generalizing well here, and so on? Yeah.
Yeah, very good question. I think that is exactly what the Compass AI project that I shared with you is going to do, because that is literally what we didn't want to limit ourselves into centers that have the facilities and the basic already the infrastructure, or maybe already the funding, the resources in the hospital. But we want to know whether it will also work in centers where there are no facilities or only limited facilities. Because I do believe, and those are the studies always in the imaging, is that if you compare the AI as an assistant to an expert, or AI as an assistant to the general radiologist, that the benefit is the most significant for the general radiologist. So AI, I mean, in our Western, maybe very developed world, we do not maybe benefit that most from AI. But it's those regions where you do not have the highly subspecialized care, and AI can bring that expertise to those regions. And I hope with our project in a couple of years, I can show you the results and can tell you like, okay, this is the guideline of how we should use AI in that kind of centers, which obviously will be completely different than in other advanced centers.
Carl, do you want to say anything?
Yeah,
We have another 5 minutes, very quickly, and if we can pick another 2 questions maybe, but yes.
No, I totally agree. I just want to add that we may have models that work even in one single hospital. It doesn't really mean that a model has to be generalizable to the entire world. So that's why I think workflow from, and I also try to answer the other question on how can you generalize and make standard protocol and processes from the beginning to the end. A workflow starting from the clinical question, ending to the registry of a specific model has to follow rules. Then once we have a model that works in one hospital, that should be approved for that hospital, and then you see whether it could be validated in another hospital. If the population, for several reasons, is completely different from the one we have trained the model, then we can use the same approach to train the models on different populations. So I barely think that we can generalize models worldwide. That's probably not feasible because we are different. I mean, we have different, as I said, we don't have 2 patients equal one another. Can you imagine what happens in different countries of the world? So we should develop models, define an approach, and then maybe test the model on different population and train other models. So what do we need? We need a workflow. We need certified infrastructure, maybe federated infrastructure, like the one we have developed. And you use those infrastructures to develop models which are suitable for that specific country or even for that specific hospital.
Thank you. And we have a minute, Saila, on this question. We have many complex angles and so on. How could regulation really encompass now all these complex angles?
Yes, indeed. So the AI Act, of course, it covers all sectors. Here the medical device regulation is very important. Every time we are talking about algorithms for health, as soon as it becomes a device that goes under the remit of the medical device regulation, then the idea is that the certification would cover both the medical device and the embedded AI algorithm. So there will not be 2 different applications or assessments. It will be sort of, from the point of view of the applicant, it will be done at the same time. And then in the AI Act, of course, there is the risk-based approach, which means that there are quite a lot of AI algorithms that do not need to be certified. So it doesn't mean that every single AI algorithm has to have an approval. So it's that is in a nutshell how the AI Act works in healthcare.
Yeah, sorry, I was expecting to get another couple of questions, but I see we have Okay, very super quick question there. Super quick question, like 20 seconds.
Many thanks for this quick discussion. My name is Adriana Turkova, representing Austrian Medical Students Association. My question is directed to Ma'am Beats 10. You introduced us the AI Campus project, and I'd like to ask you about the timeline of this action. When can we expect to be able to navigate better the challenges coming along with the deployment of AI in healthcare? Thank you.
Wow. Puts a lot of pressure. No, I mean, we've already started. So especially the one that is most challenging is, I think, to get all the stakeholders together and to sit down and see what do we need. That's one thing that I've already started. And the other one is also the digital platform to build that. So the milestones for that is, well, within 1 year, definitely you will already see the activities. And of course, we need to complete and to have the results of the pilot are very interesting. There we are going to learn from a lot. So that will take a little bit longer time. But the foundation will be there already in next year, I think.
Thanks a lot. I hope it gave you at least a bit of a gist of this complex area, or this exciting area, I would even put it. And also just to thank all the panel for presenting today, for discussing these issues. And also special thanks also to my colleague Andrea, who is in Brussels now, because she has put a lot of effort to create this thing for the last weeks and months, I would say. So she's not here with us today, but she's watching us from Brussels somewhere. Okay, thanks a lot.